Right, okay, ladies and gentlemen, while you sort of settle down, we're going to start for the next session now between now and lunchtime. So three different sort of talks really, but in some ways all sort of relevant. It's a pleasure to... How long have you been with us now, Thanos? How long have you been with us?
10 years.
Is it 10 years? Gosh. So Thanos, as most of you will have met Thanos, I cannot even begin to pronounce your surname. Just say your surname. Go on, say it.
Charalampopoulos.
Yeah? Do you get that? That's
simple, isn't it?
Simple, yeah. Thanos is a cardiologist and been with us in pulmonary hypertension for 10 years. And one of the things that everybody will have had at some stage, you got PH, and is an echocardiogram. And it's one of those crucial tests. We talk about it a lot in PH and about people having access to echocardiograms as a diagnostic thing. But I think sometimes it's also really good to know why we do it and what the history of it is. And the last time we met here, which was quite a long time ago, you did this talk, and I sort of was fascinated by it. So I really want to repeat. I'm going to press repeat button, okay? And the technology, I know you've got some moving images on this, so good luck with that, okay? It's not my fault if they don't work, but over to you, Thanos. Okay.
Thank you very much. Good morning to everyone. Thank you. Ian, thank you very much for the invitation and the very kind words. Usually we talk to colleagues, so this is a very special meeting because you are special. And it is a privilege for me being with you today to talk a little bit about echocardiography. Okay, so the first thing I would like to say to you is, can you hear me? Yeah, okay. The first thing is, the best analogy is the baby scan. So it's an ultrasound, and we can look into the body, and we can look, for example, we can have a look at the baby, but the same thing happens with the heart. We can see the heart, and we can see the heart moving as well. And that can give us very important information about what's going on with the heart. Okay, so I've got a question for you. Okay, what is the origin of the word echo? Is it from Latin, Greek, English, or Arabic? Okay, so 56% Greek. Yes, you're right. As David said, everything comes from Greek. So there are so many words of Greek origin. So ichos in Greek means sound. So this is because we're talking about ultrasound, okay, when we talk about echo. But also in Greek mythology, Icho, was one of the nymphs. She was very beautiful, but she couldn't speak. She could only repeat the words spoken to her. So she fell in love with a very handsome young man, Narcissus, and she couldn't express her love to him. So Narcissus fell in love with himself because he couldn't love anybody but himself. Something like our politicians, I think. So this is the story behind this very beautiful nymph carrying the name echo. So what is echo? Is sound waves of high frequency. They're produced by a probe, by a transducer. They are penetrating the chest, transmitted into the heart, reflected back to the transducer, and the transducer can take this information and reconstruct the image of the heart. So schematically, here's a probe. It produces these red waves, which is the ultrasound. The object is the heart. So this sound is reflected back. This is the blue dotted lines. And it is received by the transducer. And then you have the reconstruction of the mirror image of the heart, and you can see the heart moving on the screen. And we're talking about high frequency. The human ear can hear sounds between 20 and 20,000 hertz. But dogs can hear ultrasound, so over 20,000 hertz. So if your dog tilt their head to an imaginary sound, they may be able to hear sounds that the human ear cannot hear. So it'd be interesting to have a dog in the echo room and see if they can hear the ultrasound. Okay, so this is what it looks like. So you have the patient lied on the left side. I'm sure you're all familiar with this picture. And then we have the ECG stickers on the chest because we record ECG, which is the heart rate, at the same time with the echo. You have the doctor or the sonographer who moves the transducer, the probe, on the chest. And then we have the screen, and we can look at the screen and we can see what the heart is doing. What is not in this picture is that the room should be dark. So it's all done in darkness, isn't it? Okay, so why echo in pH? So when pH is suspected, we need to do an echocardiogram as a first-line test to support the suspicion of pH. We cannot make the diagnosis of pH with an echo. We need to do the right heart catheter, but we can tell how likely it is someone to have pH based on the echo. Why? Because echo does two things. One is give an estimate of the pressure in the lung, and the second assesses the size and the function of the right side of the heart. Okay, I've got a question for you. So the question is, how many chambers does the human heart, have? So the answers: 1, 2, 3, 4, or 5. Well done. Yes, 4 chambers, 71%. Thank you very much. Okay, so all mammals and birds, they have 4 chambers. Fishes, 2. Amphibians like frogs, 3. And I'm not aware of any creature having 1 or 5 chambers, but I don't know, there might be some. Okay, so these are the 4 chambers of the heart. You can see 1, 2, 3, 4 chambers. Okay? And this is what is called right ventricle. And this is what is called left ventricle. And which one is bigger? This is from someone with no pulmonary hypertension. The left ventricle is bigger than the right. Okay. But if there is pulmonary hypertension, the right ventricle becomes larger than the left ventricle. So you can see the difference between the two. So when we see the right ventricle to be enlarged, that makes us think that probably the pressure is high in the right ventricle, and that makes us suspect that this might be pulmonary hypertension. So this is how we use echo to support the evidence, the suspicion of pH. Okay, that's fine. But we also have color as well. So you can see that there is this blue color here. So that shows leakage through one of the valves of the heart. So the valves are like the doors in our house. They open and they close, and they allow us to get from one room into the other. So the valves, they open and they close, and they allow blood to go from one chamber of the heart into the other. And when they don't close, the valves, they don't close very tight, then you have leakage. You have blood going backwards instead of going forward. And we use this leakage to estimate the pressure in the lungs. We use some fancy mathematics and formulas doesn't really matter. But I'm just explaining to you how we can estimate how high the pressure in the right side of the heart and in the lungs is. And why do we need to repeat echoes? This is to assess the response to treatment. Because a good response to treatment consists of lower lung pressure before and after, and a smaller and better functioning right side of the heart. And this can guide us to make a decision about treatment change. So you can see this one. So this is before treatment, and this is after treatment, after 4 months of treatment for PAH. So what differences can you see? Smaller. The right ventricle is now smaller. Any other change? Less blue, exactly, less blue, so there is less leakage through the valve. And this is because the right ventricle has become smaller, has shrunken. So if we see this picture, we are very happy with the response to treatment, and we know that things have improved. So I could probably finish by saying that echo and probably ultrasound is the best imaging modality in medicine. First, because it is simple to do. There is no radiation. It's all sound waves. It can be done at the bedside. It is widely available. You can have it anywhere. It's non-invasive, doesn't involve any needles. It is acceptable by you. Some of you may not be able to undergo an MRI scan because of claustrophobia or other reasons, pacemakers, but I think everyone can have an echocardiogram. And it's also cheap. And most of the time, it can provide us with information we need to know. Okay, however, it is an intimate test in the sense that we need the chest to be exposed, so you need to strip to the waist, and then that's why you should be offered a gown, and you're entitled to have a chaperone in the room during the test. So I would like to thank you, first of all, for your attention, and second, for helping us being better human beings by looking after you. And this is the snake pass. If you come from the other side of the Pennines, you're very familiar with this road. It looks very nice and idyllic, but if the weather is not good, I think it can be quite tricky. Anyway, but it's a very, very beautiful place anyway. Thank you very much for the attention.
Thank you. Thank you, Thanos. You know, whenever I hear a colleague speak, I always wonder which bit I would like to be like them. I'd love to have his charm. It's just charming. You're just charming. I find it almost nauseating that he's so charming. Okay. But you are a very good clinician. We are moving on. Has anybody got one question? Has anybody got an interesting question? Well, anybody would like to? Can I ask you a question then, Thanos? Is echo something that should be repeated more than we do? If we had more time, would you think there would be a benefit for patients to have that? How often do you think, for example, if you could have what you wanted as a cardiologist with echo, how often do you think it'd be really good to echo a patient? Or is that really an unfair question? I'm still asking it, even if it was. But
I think the first question is how you're doing. If you're doing well, if you're stable, if you're feeling well, we don't need to repeat an echo most of the time. But if there is any signs of deterioration, if you think that things are getting worse, we want to have another look at the heart and see what's going on.
Sorry, one other bit of the question then is that does an echo need to be done in a specialist centre, like by somebody who's expert, or is it something that could be done in different places? What do you think about the quality of stuff?
It is very much operator dependent, but it can happen everywhere. And what we do now, we we are able to transfer images from your local hospitals over to us and have a look at the images. So you don't necessarily need to have the echocardiogram in Sheffield. It's not a very specialist test. Anybody can do it. And we can always have a look at the images and give an opinion. So yes, it can happen everywhere, I think, yeah.
Okay. One question, yeah?
No, I don't need that. I can shout. I just want to know, do you get a better understanding of the pressures from a right heart catheter than you do from an echo? Can you get a pressure from the echo? Or?
Yes, we can take an estimate, but not as accurate as the right heart catheter. Because with the right heart catheter, we get the tube into the right side of the heart and we measure the pressure directly. With the echo, we can only give you an estimate, which can be very accurate in about 50 to 60% of the cases. But in about 40% of the cases, we may not be able to give an accurate estimate of the pressure, and the right heart catheter becomes inevitable in this case, I think. I mean, we need to do a right heart catheter always to make the diagnosis. So, but I'm talking about repeat right heart catheters.
Thank you. Thank you. Thank you very much. Okay.